Okay, I'm Jack Tay. I'm an assistant professor of urology at the Singapore General Hospital. Very happy to be here today. Favorable intermediate risk prostate cancer is defined as prostate cancer that is of a Gleason score of 3+4, or in today's parlance, it would be prognostic grade group 2. And typically, these cancers have a PSA level of less than 10 and have a clinical T2A stage on digital rectal examination. Prostate cancer can really be stratified into many different risk levels. Prostate cancer really exists on a whole spectrum of disease. You have cancer that is very indolent or slow growing versus cancer that is very fast growing or aggressive. The slow growing cancers, which usually have a prognostic grade group of 1, these are low risk prostate cancers. They sometimes progress only over 15 or 20 years. In fact, long-term studies show that at 15 to 20 years, only 1% of men with these cancers die from it. On the other end of the spectrum, you have more aggressive cancers that have a prognostic grade group of 4 or 5. These are generally classified as high-risk prostate cancers, and they may progress over a much shorter period of 2 to 3 years. So for intermediate risk prostate cancers, these usually occupy a spot that is in between. And for favorable intermediate risk cancers, these typically, if you put them into that spectrum of a ballpark of perhaps 5 to 10 years before they progress. So that's how these cancers differ. Well, the good thing about favorable intermediate risk prostate cancer is that like I said, they exist on the spectrum of cancer that is more slow growing. So first, there's a lot of reaction time. I often tell my patients to take their time to decide, and there's no need to rush into any decision for treatment. When it comes to the menu of treatment options, these are actually really extensive. And often what the patients need to grapple with is that they have so many options to choose from, ranging from doing nothing or just observation, which is what we call active surveillance, all the way to doing radical treatments, which includes removal of the entire prostate gland or perhaps radiation therapy to the whole prostate gland. And there are also the spectrum of treatments that exist in between. For example, many patients are interested to do focal therapy, which is to treat just the area of cancer within the prostate. And for favorable intermediate risk prostate cancer, these are often the perfect candidates because the cancer is often it grows slowly enough for the treatment to work very well. And these cancers, if they are localized just to one spot in the prostate, we could actually treat just that spot of cancer and thus avoid damaging critical structures around the prostate, which if those would be affected doing radical treatments such as removal of the entire prostate gland or irradiating it, and these often lead to many side effects. So doing a treatment such as just observation or perhaps treating just that spot using focal therapy, we're able to avoid many of the side effects of standard treatments. So the standard treatments, and I tell my patients that the gold standard for treating prostate cancer, which is localized to the prostate, really is removing the entire prostate or irradiating it. And these are the gold standard treatments because the outcomes are so good. I think for favorable intermediate risk cancer, if you use the standard treatments, the chance of having the disease recur is probably less than 5% most of the time. However, the price to pay is that there's a huge impact on the quality of life. So two of the main impacts on the quality of life are with regards to urinary function, sexual function, and for some patients, the bowel function as well. After removing the prostate, men often become incontinent and they have leakage of urine. Now, for most men, this may recover to some extent, but for other men, this may be a permanent problem. For sexual function, these get affected as well because of the erectile function nerves that are around the prostate. And if these are disrupted, whether through surgery or radiation, men lose their ability to have erections, and this affects their sexual quality of life. Radiation therapy is often very effective, but it affects the bladder and the rectum, and this results in bleeding from urination and also bleeding when one passes motion. And this could occur usually not immediately, but usually occurs 3 to 4 years after treatment. And when this does occur, it can sometimes be a permanent and protracted problem. Yes, active surveillance is an option for favorable intermediate risk prostate cancer, and whereas for low risk prostate cancer, those are low risk prostate cancers are the ones that are most suited to active surveillance because of their extremely long horizon to progression and metastasis. However, in selected cases for favorable intermediate risk prostate cancer, men can avoid treatment and just be on observation for a period of time as well. Often what we are trying to do is identify the most aggressive cancers and identify these cancers for treatment. So through active surveillance, we're able to observe and look at the behavior of the cancer. If the cancer is progressing over time, that's an indication to intervene and treat the cancer. So one strategy is to go on active surveillance for favorable intermediate risk prostate cancers. But on the other hand, some of the long-term studies have shown that between low risk and favorable intermediate risk cancers, between the men who have low risk or intermediate risk prostate cancers who are going on active surveillance, it is the men with intermediate risk prostate cancers that actually demonstrate progression over the years. And in fact, these men may often require radical treatment anyway at some point in time during the surveillance. For favorable intermediate risk prostate cancer, the chances of the cancer progressing and spreading are very small. This cancer being favorable intermediate risk really puts it on the spectrum of more slow-growing cancer. So I always tell my patients there's a lot of reaction time. You could take some time to think about it. In fact, some studies done in which there was a delay to treatment for 6 to 12 months. There was no impact at all on the eventual outcome of these patients. So really, some men opt to go on surveillance and a period of observation. In fact, to even repeat their imaging or biopsy studies a year later to see whether there is any rapid progression before they undergo treatment itself. I think age and overall health play an enormous role because age and overall health impact and predict the lifespan of men. For example, a very elderly man who is in poor health and has multiple cardiac or other medical issues has a shorter life expectancy than someone who is younger and extremely fit or healthy. Now, this is important because prostate cancer is such a slow-growing cancer, especially those with favorable intermediate risk cancer, that the issue of what we call competing morbidities or competing mortality comes into play. And competing mortality essentially is a measure of will a man die from this prostate cancer, or will a man suffer from the consequences of the prostate cancer, or is he more likely to suffer or die from other illness? And if the chance that the man will suffer or die from other illness is high, then by treating this prostate cancer, we're actually giving him the side effects of treatment with very little benefit. However, if somebody has a long life expectancy and is expected to suffer from the effects of prostate cancer, then treating that cancer early, will actually impact his overall health more. So age, in that context, I would say that age and overall health are absolutely critical in terms of selection of treatments. Well, right now there is no clear evidence of the role of genomic testing in favorable intermediate risk prostate cancer, although there are some tests that now exist to help patients decide whether or not they would progress while they are on active surveillance. So these tests are available for those with low-risk prostate cancer because some of their endpoints really have been whether they progress to intermediate risk later or not. So one of the main issues with having intermediate risk prostate cancer is that it's difficult to quantify what constitutes progression, whether they progress onto unfavorable intermediate risk or not. So I think the jury is still out on these genomic markers in this particular context. So while these tests do remain available, I would counsel my patients that it has to be taken into the overall perspective of the other clinical factors as well. I think that depending on what treatment options you choose, I think improving your chances of cure depends very much on what kind of treatment options you choose. If one is on surveillance, I would say that adhere to the surveillance protocol. Most prostate cancers in the favorable intermediate risk category are very slow growing, so it's easy to detect whether there's going to be cancer progression by attending the surveillance imaging visits, doing the surveillance biopsies, and that is able to inform us of whether some intervention is required. If one chooses to go for focal therapy, there is a surveillance program after that as well. After focal therapy, up to 80% of patients do not require any further treatment, but there are about 20 to 25% of men who may have recurrent disease or persistent intermediate risk disease that perhaps require repeat treatments or conversion to radical therapy. So adhering to one's doctor visits, attending the imaging and having the biopsies are important. If one feels that cure is extremely important, even though if one wishes to pursue a 100% chance of cure, then radical treatments such as prostatectomy, removal of the prostate, or radiation therapy may be the best option, but one has to be aware that these come with a lot of side effects. Many of my patients often choose a more conservative approach with surveillance first, perhaps focal therapy, and then if there's still cancer persistence, they move on to having radical treatments. This paradigm of going through the treatment ladder is very appropriate in favorable intermediate risk prostate cancer in order to minimize the harms of treatment. On the other hand, there are patients who do not prefer a conservative strategy, and they are perhaps of the more anxious mindset and really wish to be clear from cancer. They're willing to deal with the side effects of treatment, and in those patients, having a prostatectomy or radiation therapy would put them in the best position in terms of making sure that there's no cancer that persists.